Welcome. Thank you for registering for the Penn Memory Center's Caring for the Caregiver class. Up until now, this class was only available as a live class. Today, we're delighted to bring you this recorded version of the class. While there's great value in being in a live class where there is an interactive group setting with opportunities to share and learn from others, we recognize the restraints and conflicting obligations you have as caregivers, and we hope to offer you something that you can take away and that's valuable for you in teaching tools and skills that will help you with your caregiving experience. My name is Felicia Greenfield. I'm a licensed clinical social worker, and I'm the executive director of the Penn Memory Center. I lead a team of social workers who are available to support families followed at the Penn Memory Center. I've been running this class in a live version since 2011, and I'm amazed at how it's grown in popularity and demand since then. I want to first thank you for completing your pre-registration assessment forms. The data helps us understand how effective this class is, and feedback helps us modify the course to optimize your experience and others' experiences moving forward. To that end, I'll be asking you to complete the forms and provide more feedback at the conclusion of this class as well. As this is the first time we're offering this class as a recorded lecture series, we will hold office hours for the next 6 weeks. Office hours are optional, but we do ask that you pick one session and join only that session for the duration of the weeks available, which are March 10th through April 23rd. If you haven't already done so, please go to the link I sent in an email on Friday, March 5th to register for one of the sessions. The sessions will be on Wednesdays from 4 to 5, Thursdays from 3:30 to 4:30, or Fridays from 12 to 1. When you log into office hours, you can join at any time during the hour. There may be others in the Zoom room as well. It's an opportunity for you to maybe connect with others or your facilitator, ask questions, and get clarifying information if you need. Once you register for one of the office hour options, we'll send you a link to the Zoom room, and that'll be the same link that you'll use for each session. If you have any questions about this class, you can email me at any time, felicia.greenfield@pennmemorycenter.upenn.edu. I may reply to you, or I may ask one of my course assistants, Anna Kozlowska or Kelly Sloan, to respond, but one of us will be in touch to answer any questions or comments that come in. Before viewing the lectures, please have a notebook for note-taking and or journaling, and a folder or a binder to contain the class documents. All slides and class documents will be stored on a website that we'll send again if you haven't received it on Monday, March 8th. Just let us know. Make sure that you're able to access the class. The documents can be printed. The documents and homework templates can be printed and saved in a binder or folder, or you can create a folder on your computer to save them in as well and have an electronic version. Finally, before recording lectures, please find a quiet space free of interruptions. This will help optimize your experience so that you can get as much from the course as possible. I hope you find it helpful and valuable. Key goals of this class are that you as caregivers will gain a better understanding of dementia and its different causes, improve your understanding of your individual needs, learn how to harness your inner resources and strength, learn to enhance self-care while caring for someone with dementia. We hope you'll take away practical skills for managing behaviors and communicating with someone with dementia, and that you'll be able to either begin or continue planning for the future. And by way of orienting you to what we're going to be doing in the next 6 recorded lectures, the first lecture today, we're going to be talking about the program and memory loss. I'm going to give a lecture on memory loss, dementia, caregiver burden, and the importance of caregiver self-care. And I'll also teach one relaxation technique called the signal breath. In the second class recording, we're going to equip you to notice how negative thought patterns happen automatically and how they can be very unhelpful to you. I plan to help you identify cognitive distortions, and I hope that you will learn how to challenge and change maladaptive thoughts. Next, I will introduce you to our second relaxation technique called 20 breaths. In the third recording, we will start by exploring the importance of caregiver self-care. We will focus on recognizing the self-care you already may be engaging in, while also brainstorming ways to increase your well-being. Then we'll learn basic communication techniques that'll help you improve communications with your relative or your loved one that you're caring for. And these will serve as a building block for all of your other caregiving skills. I'll then introduce a third relaxation technique called the body scan. In the fourth recorded class, I will work to help you identify undesirable behavioral symptoms that you wish to change. These can be behaviors of the person for whom you're caring or your own behaviors. The ability to alter or change a behavior can improve your mood and your feelings. Then we will practice another relaxation technique using music. In the fifth recorded lecture, we're going to talk about the importance of engaging your relative in meaningful activities. We'll learn to identify methods to adapt activities to your relative that your relative used to engage in. Also, we'll learn how to brainstorm new activity ideas and introduce an activity in the most successful way. Finally, the sixth recorded lecture will provide an overview of care planning and an explanation of community resources for caregivers. We will also discuss effective methods for engaging others in your relative's care. In other words, teach you how to ask for help from others when you might need it. Before we get into the meat of the class, I want to share with you a little bit of information about the Penn Memory Center for those of you who are not very familiar with us. The Penn Memory Center has been in existence since about 1997, and we've consistently been one of about 30 National Institute on Aging Alzheimer's Disease Research Centers, or ADRCs. And what this means is that we are part of a consortium typically at academic institutions, and we receive funding from the National Institute on Aging to conduct a broad range of research on aging and neurodegenerative disorders such as Alzheimer's disease. So research is a key mission of the center. And we also have a clinical practice where we conduct expert evaluation and diagnosis of neurodegenerative disorders. We're a multidisciplinary team. We have our memory doctors come from neurology, geriatric medicine, and psychiatry. We have a geriatric psychiatrist on our team, as well as a neuropsychologist and a physician assistant and a team of social workers and research coordinators. And we are here to support patients and their families. We recognize that Alzheimer's disease is a life-changing diagnosis that affects the entire family, and so it is part of our mission to help guide families through this process. The team I oversee, the social work team, provides services that support families through education, programming, and emotional and mental health care. We work with people in the early stages of memory loss who are coping with the changes that they're experiencing, as well as their caregivers who are also adjusting to the changes of their new role as caregiver. Our neuropsychologist is available to conduct a comprehensive neuropsychological testing battery, and this is for people who may have an atypical presentation of memory loss, and people are trying to really understand what might be causing it. If this is something that is unclear from the initial evaluation, this is an option for people seeking additional information. And to find out more about our center, our research opportunities, and our programs, feel free to visit our website at www.pennmemorycenter.org. My team and I have branded the social work program, the programs that we offer, as the Caring Difference suite of programs. And these are a few of the programs that we offer. Most of our programs are aimed at supporting caregivers, and we have a few that are for the person experiencing memory loss. So this class is one of the classes that we have for caregivers, both online and live. We offer caregiver support groups, and I'll talk to you a little bit more about that later today. But at the conclusion of after you complete this 6-week course, you will have the opportunity to join a caregiver support group that meets ongoing once a month for an hour and a half. I have started a couple of years ago offering ongoing support groups for people who have lost a loved one due to Alzheimer's disease. And those groups are for people who have been part of our caregiver support group. So that's something. So once the caregiving comes to an end, there are opportunities to stay on board through a grief or loss group. My team and I offer coaching. If you ever run into a situation and could use some coaching, we are available to you for that, as well as psychotherapy, primarily for caregivers. But I do want to give out the caveat right now that both Allison, Lynn, and I are at capacity. And at this point, we have a waiting list for psychotherapy. If you are interested in psychotherapy, please let me know, and I will work with you on how to identify a provider to work with moving forward. We offer an Empowering Caregivers lecture series, which we haven't run in the past year since COVID, but Allison Lynn is my associate director, and she and I are working on restarting the Empowering Caregiver lecture series. And that is just, we bring in someone from the community to present on an area, a specific specialty area that they have expertise in that you might gain benefit from if you attend. So more to come on that. We offer monthly memory cafes. Memory cafes are designed for the person with memory impairment and their caregiver to come together. In non-COVID times, we meet in person at the Christchurch in Old City. But since last year, we've been able to offer them all virtually. And information about our memory cafes is available on our website. The Timeout Respite Program is an intergenerational program where we match students with persons with memory impairment. And since COVID, we haven't been able to send students into the homes of patients. So we have transitioned this program to something online called Weekly Smile. And again, there's more information on that on our website. Another key program is Creative Expressions Through Music, and this is a partnership with the Curtis Institute. It's currently in session, and we're not enrolling any more patients until the fall, but more information about Creative Expression Through Music is on our website as well as any other programs that we offer. Okay, so now we're going to move into the content of this class. We call this a caregiver class, a class for caregivers. You are taking this course because you identify as a caregiver in one way or another. You might be caring for a spouse or a parent, a grandparent, another relative, a friend. And in this class in particular, is specific to people caring for someone with dementia. Caregivers obviously you can be a caregiver to a child or to somebody with a disability or a traumatic brain injury or something like that. But this class is really for dementia caregivers. But broadly, the definition of caregiver means that you are providing extraordinary care exceeding what would be considered usual in a family relationship. Caregiving involves significant expenditures of time, energy, and money over long periods of time. We will talk in just a minute about how Alzheimer's disease can last for 10 or more years, and it can be exhausting and expensive to undertake caregiving in that capacity. And it often involves tasks that can be unpleasant, uncomfortable, psychologically stressful, and physically exhausting. So we just wanted to name that and recognize some of what you might be experiencing here on this slide. The Alzheimer's Association website offers a wealth of facts and figures and information and other helpful tips. They put out every year a facts and figures sheet that compiles data in the United States on both persons with Alzheimer's and other forms of dementia and caregivers. So this slide shows you some of the key findings from the 2020 Alzheimer's Association facts and figures. So 83% of help provided to older adults in the United States comes from unpaid family caregivers. Now that's caregivers used broadly. 48% of those are dementia caregivers. 48% of all caregivers are dementia caregivers, 48 out of the 83. So more than half. Family caregivers provided about 18.5 billion hours of care, valued at about $235 billion. So I know it's hard to wrap your head around numbers in the billions, but really I think the point here is that they're showing that it's a huge, potentially public health problem. And a very expensive one at that, caregiving. And these numbers compile cost of care as well as loss of wages when somebody can't work because of caregiving responsibilities. About 2/3 of caregivers are women and 1/3 are 65 or older. And caregiving can last more than 10 years, as I just mentioned. And finally, 1/4 of all caregivers are in the sandwich generation, which means that they're caring for both a parent and a child under 18. Much of the time they're working. And then this year, of course, with the pandemic, it just adds a whole other layer of complexity and difficulty. So I want to spend a few minutes talking about caregiver burden. Caregiver burden is a real defined term. Diagnosis, and it represents the interplay between the emotional, social, physical, and financial stressors relating to someone caring for dementia. So, on the emotional side, you might hear, actually all of these quotes came from people that I've worked with. I never imagined my future looking like this. I thought we would retire and travel, and now this is our life and it's really sad. So you have that emotional weight. And then socially, oftentimes people feel abandoned by their friends. Our friends are so uncomfortable around us, we really don't see much of anyone anymore. So friendships start to deteriorate. Financially, it's very expensive. Medicare, we're going to talk I think in week 6 about the cost of care, but Medicare doesn't cover much of what people with Alzheimer's disease need in terms of care. Like it doesn't cover long-term care or in-home care. And so it adds up. And then there's also the physical aspect. When somebody can no longer lift someone in and out of bed or the shower. I want to introduce you to a concept that many caregivers find helpful to make sense and understand their experience. And this is a concept called ambiguous loss. Ambiguous loss is a term coined by a researcher named Pauline Boss. And ambiguous loss is very it brings about a lot of uncertainty because the loss is not finite. So many caregivers report that the main problem with caregiving is not really the illness or the disease, but the ambiguity they feel or experience when caring for someone with Alzheimer's disease. There's a lot of sadness experienced for a person caring for someone who is here physically, but not here emotionally or psychologically. So in other words, you can see the person for whom you're caring. They look the same. Sometimes they look like nothing's changed, but they're different. They've changed. It's not the same person emotionally or psychologically. Their personality may change as part of the illness. So it's very confusing and is experienced as a loss. This next acronym here in my third bullet point, ADRD, you will see that throughout the slides, and that stands for Alzheimer's disease and related disorders. So Alzheimer's disease and related disorders causes unpredictable memory loss that comes and goes. And this can cause a lot of stress on caregivers. And what this means is that one day a person may seem great, fine, like their old self. And this makes caregivers feel hopeful and optimistic that maybe things are okay or going to be okay. But then the next day or 2 days later, they may have a really bad day. And that kind of is experienced as a kind of roller coaster of absence and presence, which can be stressful. So these kinds of losses are considered living losses, and people really don't know how to experience living losses because they're not like finite losses such as death, because there's no sense of closure, there are no ceremonies or rituals, and it's just something that is kind of ongoing and ever changing. And then ambiguous loss can cause ambiguous feelings for caregivers, oftentimes leading to depression and anxiety, and driving caregivers to feel immobilized, and feeling isolated, sad, guilty, or full of shame. And so think for a minute and possibly journal in your notebook about this concept of ambiguous loss and how your experience may or may not fit into this construct. One driving goal of this course is to help you as caregivers enhance your self-care and reduce stress. And so we can do this by we can try to achieve this through a number of different avenues. So identifying and kind of naming the positive aspects of caregiving. People have said that sometimes it feels good to give back to a parent or to a spouse who's done so much for you. And people have a whole host of other positive aspects of caregiving. So it's important to journal about or reflect on those. We also can improve our well-being by understanding how our thoughts affect our mood and our behaviors. We're going to spend a bit of time in just a few minutes talking about that idea. And to do this, we sometimes will have to challenge some of our cognitive distortions, like catching ourselves when we're having a negative or unhelpful thought, and challenge and change that thought. We want to learn how to express and accept negative moods. Sometimes we want the pain to stop. We want the sadness to stop. We want to stuff it down and pretend it's not there. But that that's not helpful. Sometimes we need to just accept it and learn how to express it in healthy ways. We want to move our anger to empathy. So we feel angry sometimes that our loved one is sick and or that we have to take care of them and give up other things to do so. But it can be helpful for us to recognize that anger, but also have empathy for the person with the illness. This is not something they're doing on purpose. It's not something they asked for. And it's important to recognize the loss that they are experiencing as well. Part of this course is identifying things to do that make you feel good. So identifying pleasant activities or events to help balance the burden of caregiving. In this course, we'll learn communicating with your loved one with dementia, and also relaxation skills are certainly a big way to help with stress reduction, as is learning to identify other people to support you and practicing how to ask for help you need. So this class really combines three concepts to help you optimize your skill set and your self-care. So the first concept is cognitive behavioral therapy. Many of you may be familiar with cognitive behavioral therapy, but in short, it is to the right, you'll see a triangle, the cognitive triangle. Your we all have thoughts. That's the running monologue that runs through our mind. Sometimes it's our inner critic. Sometimes there's chatter in our heads that we just can't stop. Those are our thoughts. And those thoughts affect the way we feel, and they also affect the way we behave. And then you see the arrows in that triangle going in each direction. The way we feel also affects the way we think, and it affects our behaviors. And our behaviors, the ways in which we behave, also affect our thoughts and our feelings. And a change in one can lead to a change in the other. Now, we can't change our feelings. The feelings are the one things that we can't say, hey, I want to feel happy. But we can change the way we talk to ourselves or the way we think or the things that we do. And if we are able to change our thoughts, our behaviors, the outcome could be an improved emotion. So that's one concept that we'll talk a little bit more about. The next concept in this class is stress reduction through mindful responsiveness. And this really means mindfulness and learning how to take a minute to breathe and find some sense of peace and relaxation. And then the third component is support from a group of people going through a similar experience. Now, that's obviously going to be stronger in the live class when people are together taking this course, but certainly either through office hours or through the support group that you are eligible to join after the completion of this course. You will have ongoing support from other caregivers. And these support groups we've been running for over, since 2010 or so. And many people consider their support group their lifeline. Now I'm going to shift gears and go over some key components of memory loss or memory change, just a very basic overview for you. So as we age, we all start to lose some of our cognitive functioning. So, even after the age of 25, we start slowing down, certainly by 40, 50, but when we're in our 60s, things might start to feel a little bit slower. So we might find ourselves making bad decisions every now and then, missing a monthly payment on a bill. Especially now during COVID, I think we all forget which day it is because every day seems to be like the day before, but this, kind of forgetting what day it is, but then, oh no, never mind, it's not Friday, it's Thursday, that's normal. And we all have this tip of the tongue phenomenon, which we might drop a word or forget what word we're thinking of, and we might lose things from time to time, but generally we have the ability to retrace our steps and find them. And, when people are in their 60s or 70s and they're experiencing some of these changes, sometimes it feels concerning or scary. Alzheimer's disease by the way, it is the most feared disease among older adults. And so people are very sensitive to this. But if you're experiencing any of these changes, that is normal. And the next slide, we're going to talk about when it might be time to see a memory specialist. So this slide indicates some problematic changes in memory loss in older adults, and this is when it might be time to visit a memory specialist. If you're having consistent blips in judgment or real difficulty making decisions. The ability or the inability to manage your money, paying multiple bills or forgetting bills, or mismanaging money or spending irresponsibly. That's an indicator that it's time to visit a doctor. And I don't mean just spending irresponsibly. I mean like change in baseline from how somebody managed money historically. If you're noticing somebody unable to keep track of the season or having real difficulty following the thread in a conversation, these are indicators of a problem. And then, we all lose things from time to time, but somebody who can't actually retrace their steps to find the things that they've lost is concerning. You might see problems with visual and spatial relationships, and also difficulties in planning for the future or solving problems. Calculating a tip, for example, is a big one that we see, or somebody who, just can't really figure out a simple task. I do want to say that more often than not, the person with the memory problem does not recognize these changes and may deny that they're having some of these problems. It's usually somebody close to them, somebody who spends a lot of time with them, who knows them well, who notices these changes in another person. So I just want to point that out, that the person themselves having the memory problem is unlikely to pick up on these things, to notice these things, but it's very noticeable to everybody else that's close to them in their lives. So I still get this question a lot: what's dementia? Or what's the difference between Alzheimer's and dementia? I get that all the time. But I want to start with dementia, because dementia is a generic term. Dementia is an umbrella term or generic term that describes a set of symptoms that include loss of function serious enough to interfere with daily living. So, in other words, a person's baseline level of functioning is changed, and they can no longer do things that they once could, and it's affecting the way they live day to day. And dementia can cause changes in memory, language, thinking, navigation, behavior, and personality or mood. On this slide, this is just a little visual graph to show the difference in cognitive decline over years. So at the very top of this graph, you have normal aging, and those green arrows indicate change over time as someone gets older. You see on the bottom of the graph, it's time in years going from left to right. And on the right side of the graph, you have cognitive decline. So everyone experiences changes over time, and you'll see that the changes are different in different people. So the green arrows on the top show different rates of change that are still within the normal range. Okay. And then we have these categories: preclinical, MCI, and dementia. Preclinical, what that means is that even before there are signs of memory loss, and loss of function, people might have the pathology in their brain. The amyloid and plaques that cause Alzheimer's disease may be present before there are symptoms. So this is what we call the silent phase. There are changes happening in the brain that are not noticeable. People might notice them, though. Individuals or people who know the person well might see the changes, but they're not detectable on tests. And so this is often referred to as the stage where the patient knows, but the doctor doesn't know. And this can be a very frustrating stage for people, because their doctor it might feel invalidating for a doctor to just say, nope, everything's normal, you're testing normally. But there's this kind of nagging suspicion that something is just not right. And now with advances in technology, we can do PET scans that can detect amyloid or tau on a person's brain that can actually diagnose somebody as preclinical, but these are not readily available, or they're not available at all clinically yet, only in certain research protocols. Okay, so that the blue line, you see under the normal aging and above the preclinical, you see a blue line, and that's kind of a departure from normal aging. We're starting to see the line go down a little bit on the cognitive decline scale until it goes down to this category called MCI. MCI stands for mild cognitive impairment, and those are changes that are concerning. They're starting to It's really getting noticeable at this point. And we're noticing that there's one or more domain that are impaired pretty significantly, not in the level of dementia, but notably marked difference from baseline. Yet the person still is able to function as though everything is okay, and it doesn't really affect their activities of daily living. So those cognitive domains I showed on the last slide relate to memory, language, thinking, navigation, behavior, and personality. So you might see one or two of those that are slightly more impaired. So you have that darker navy line that is a departure from the preclinical AD. So a person might stay in that kind of preclinical, blue line, which never really develops into dementia. But some people who have preclinical AD and who then go on to get a diagnosis of mild cognitive impairment, some of them stay just that way, but some of them continue to decline until they're considered in this dementia level of impairment. And so that's where the red line begins here. Dementia means cognitive impairment severe enough to interfere with everyday abilities. It affects memory, thinking, behavior, navigation, mood, and personality. And dementia has different stages. So there's mild dementia, moderate, moderately severe, and severe. And just the red line alone of dementia, starting in the mild stage to the severe stage, on average, a person can live for 8 to 10 years with a dementia diagnosis. So it can last a lot, and some people longer, but some people not. Some people fewer than 8 years. So it's a wide range, but on average, from time of diagnosis, a person can live with dementia for, on average, 8 to 10 years. So we answered the question, what is dementia? Dementia is an umbrella term that causes changes to memory and thinking and functional impairment. This slide, so that's the first question, what's dementia? Then the next question that you want to ask is, what's causing the dementia? Okay, so this is a list of common causes of dementia. So Alzheimer's disease in the United States is the most common cause of dementia. There are other things that cause dementia: vascular disease, frontal temporal dementia, dementia with Lewy bodies, Parkinson's disease can cause dementia. And all of those, Alzheimer's, vascular, FTD, DLB, and Parkinson's, those are all, as of now, non-reversible. Once somebody has dementia due to one of these diseases, there really is no cure or treatment for them beyond what I'll tell you in just a couple minutes. Okay, but there are some things that are reversible causes of dementia, and this is why it's important to have an evaluation. People with severe depression or anxiety can present as though they have dementia. So if treated, the dementia could go away. If there's not a biological cause for the dementia, the biological causes are ruled out. It could be something psychological like depression or anxiety. We test for blood. We test blood for vitamin B deficiency and thyroidism, hypothyroidism, because both of those can also look like dementia. But if they're treated, that is a reversible, that a person will go back to normal. Somebody who has a significant drug or alcohol misuse disorder over a significant period of time can present with dementia, but if that is treated, that could reverse. And tumors also. We do MRI scans. MRI scans don't show dementia or Alzheimer's disease, but they will show us whether there's a tumor. And they also show us if there's been some strokes, which can cause, that would be vascular dementia. And we can also, in the scanners that we have at Penn, which are really powerful, we can also see, we can measure hippocampal volume through our MRIs, and that's another indicator of Alzheimer's disease. So infections, finally, is another reversible dementia. Oftentimes, older adults who are significantly dehydrated will develop a urinary tract infection, and that can present like dementia, but once fixed, that can correct itself. So I just want to briefly go over the diagnostic process at the Penn Memory Center. When somebody calls to make an appointment for a memory evaluation, we want to make sure that both the patient attends and a family member or another person that we call a knowledgeable informant, someone that knows the family well. It's really hard to make a diagnosis if somebody doesn't have somebody there to provide collateral information, given the nature of memory loss. So we interview them separately. When we're in person, we send the patient into a room with a tester, and the doctor is interviewing the informant for collateral information. And then the doctor brings the patient back into the room and conducts a bedside examination. And we take together that along with the testing that they've done to help kind of put together the case for a diagnosis. And so this neuropsychological testing, we use a mini battery. It's about 20 minutes long, and we're testing kind of short-term memory and thinking and language and visual spatial outcomes on those tests. As I mentioned in the last slide, we then, after the in-person visit, we send people to have blood work to rule out the infection or other possible reversible causes of dementia. And then we have people get an MRI, and this is where we check the hippocampal volume. We look at general brain atrophy. We can see if there are any, if the person's had any strokes that might be creating some, vascular disease, and also rule out tumors or infections. So the testing, the informant information, the blood work, and the MRI all go into the doctor coming up with a diagnosis that seems consistent with the diagnosis that they give. Sometimes we ask people to have a PET scan or a lumbar puncture, or to come back for some more extensive neuropsychological testing with our neuropsychologist. if the the initial exam is still inconclusive. We're pretty good. We've seen many patients over the years. Our diagnostics are quite good, but they're not perfect. And still the only way to give someone, 100% accurate diagnosis is through autopsy. So we actually do ask people in our research study, our ABC study, which stands for Aging Brain Cohort, anyone who's in that study, we ask them to consent to autopsy after death. And people who do consent, we give the results of that autopsy back to families so that they can see what was causing the dementia. And we can tell if our diagnosis was accurate. But really, at a certain point, if somebody is experiencing dementia and really struggling, diagnostic specificity becomes less important than supporting patients and caregivers in managing and care planning. And part of this, or a main reason for this, is because as of now, there is no treatment. There's no cure. And so we just have to learn how to live with the disease. We have seen people who go down a rabbit hole of trying to pin down a specific diagnosis. If the doctor's having a hard time, it's not a perfect science, and there are so many confounding factors. It may be many things. That there might be 3 things going on. A person, we see this a lot on autopsy. A person might have pathology for Alzheimer's. Their frontal lobe may be affected, and they've had some white matter damage due to vascular disease. So they have 3 things going on that might be causing the dementia. So really, the takeaway here is that dementia is dementia, and at a certain point, we have to figure out how to care for someone living with this set of symptoms. So Alzheimer's disease is, I mentioned, the #1 cause of dementia in the United States. Alzheimer's disease is defined as a brain disorder. It's progressive, and so far there is no cure. It has no cure. And here is a picture of amyloid and plaque. Plaques and tangles under a microscope, which are the hallmarks of Alzheimer's disease. And so that's just a picture of what it looks like. These are normal proteins in a brain that turn abnormal and start to affect different areas of the brain. In Alzheimer's disease, it starts in the hippocampus, which is our kind of short-term memory place, and then they spread throughout the brain and affect different parts of thinking and functioning. Here's a picture of a human brain, and it's a lot to go over in a recorded slide, but that's there for your reference. You can see at the bottom where it says the limbic system, to the right is the hippocampus, and that is where we store our short-term memories, our most recent memories, before our brain encodes them and they become long-term memories. And when the hippocampus shrinks, a person doesn't have the ability to store that information, and that's why you hear repetitive questions maybe every 5 minutes, or a person might be telling a story and they forget what they were talking about, before they get to the end of a sentence or the end of a story. Their hippocampus is significantly shrunk due to Alzheimer's disease. And then, as the disease progresses, that's the first part that's affected in Alzheimer's disease, but it can spread to the frontal lobe, which affects our executive functioning or our ability to plan. Also, our personality is affected when the disease, if the disease moves to the frontal lobe. It does not always. It's different in every person. You'll see the temporal lobe over to the right, and that's where language, that's the part of the brain that manages language. And if that's impaired, then a person might have difficulty coming up with the words or having a coherent conversation. The amygdala is to the left of the hippocampus, and this is where our emotions are stored. And sometimes that, if that part of the brain is affected, a person will have poor, emotional control. So that's just a pictorial for you to look at, to kind of try to understand the different parts of our brain and how our brains might be affected if we develop Alzheimer's disease. This graph is almost just like a different version of the other graph. So except it shows the difference in different kinds of dementia. So you have cognitive function, again, going down the left side of the graph, and then you have time on the bottom, and it looks at progression. And so you see the green dotted, or the green kind of dashed, I guess, line that goes from normal down, like kind of a clear slope down the over time. And that is your kind of standard Alzheimer's disease. That's the way it progresses, just a steep, slow decline over time. The red line, multi-infarct dementia, that is another word for vascular dementia. So you'll see it at normal, it's like a plateau, and then a quick drop to subtle deficits, and then a plateau again, and then another decline down where it says like obvious deficits. There's a couple of declines, and this is what we call stepwise progression. People with vascular dementia will progress in their illness like that. So everything will be good, and then there will be a steep decline, and then stable for a while, and then a drop, and then stable, and so on. And then the third category reflected in this graph is an acute problem that causes some decline. So that's the blue kind of hash, that's a curve. And you'll see somebody, it might be a stroke or something where on the plane where someone's doing okay, there will be a steep drop and then go back to the plane. So that's just, I might not be explaining this graph wonderfully, but it's for you to help in your understanding of the different types of progression, depending on what kind of diagnosis your loved one has been given. So I mentioned before that there are 3 primary stages of Alzheimer's disease: early, moderate, and late. And in the early stages, this is where we see forgetfulness, short-term memory loss, some confusion, difficulty decision-making. Money and directions can often be confusing and difficult to navigate. People in the early stages of Alzheimer's disease seem more tired, and sometimes it's not very noticeable, but it's just a little bit. They just seem a little bit off, a little bit different. They might be making odd judgments or making inappropriate jokes or social faux pas. Repetition is very common because of the hippocampus and inability to store short-term memory. They might forget that they've said the same thing, 5 times in a row. So that's a sign of early stage. And people might get confused about times and places. Sometimes these things seem drastic, and caregivers often think that the disease is progressing rapidly, but these things are really considered early stage. I should have mentioned in the last slide that the early stages of Alzheimer's disease can last, 1 to 3, 4, 5, even years, depending on the person. And then maybe 5 or 6 years in, your loved one may start to progress into the middle stages of Alzheimer's disease. Middle or moderate is another word for it. And this can be the most difficult stage of the disease. This is where people have a lot of anxiety, and that anxiety might come out by wandering or pacing. They may have difficulty recognizing family and friends, people who are very close to them. And this can cause anxiety for both that person with Alzheimer's disease and the loved ones who are being forgotten. Because of this anxiety, people become more impatient, restless, and irritable. In this stage, learning something new is just not possible. Folks in this stage have real significant trouble organizing and expressing their thoughts. You might see paranoia. They can become suspicious of others, and there might be some auditory or visual hallucinations, thinking that things are there that are really not there. Oftentimes, these hallucinations don't really scare or bother the person with Alzheimer's disease. They might scare you more than they scare the person, so just keep that in mind. Dressing becomes difficulty. Dressing for the appropriate season is often difficult, and they may resist being helped because they don't really have insight, and you might see more aggression during this stage as well. The final stages of Alzheimer's disease are short and may last anywhere from a few months to a year. And in the final stages, people with Alzheimer's disease are unable to perform most activities of daily living. Bladder and bowel function becomes more difficult. They are unable to communicate or follow simple directions. They seem to retreat into themselves and may engage with people and talk about things that are not real. Oftentimes people are irritated easily and need assistance walking or sitting up. Much of the day may be spent sleeping, and just tend to appear more withdrawn from the world around him or her. And it's usually in this stage of illness where people talk to a doctor about hospice care, end of life planning, sorry about that, and things of that nature. So, like the earlier slide I showed you with facts and figures for caregivers, the Alzheimer's Association put out their 2020 facts and figures for Alzheimer's disease. So we know that Alzheimer's disease is the only cause of death in the top 10 causes of death in the United States that cannot be prevented or cured. 2/3 of Americans with Alzheimer's disease are women. 1 in 3 seniors dies of Alzheimer's or another form of dementia. It's the 6th leading cause of death in our country. An interesting statistic to me is that only about 45 people with Alzheimer's disease are told of their diagnosis, compared to about 90% of people with cancer. This might be something worth exploring in your journal, why that might be. But I think that the general consensus is that the majority of Americans don't live near academic research institutions like Penn, and are maybe in a part of the country that has doctors who are not well versed in Alzheimer's disease. Oftentimes doctors identify as healers and fixers, and this is an illness with no cure, and so doctors feel uncomfortable with this disease and may skirt around the cause of, or may skirt around a direct diagnosis. Cancer, there are more, there's more science behind, there's more research backing cancer. There are more treatment options. So I think that, they're just, we don't know why this is, but people speculate as to why people with Alzheimer's disease are not necessarily told by their doctor or diagnosed directly. In 2018, caregivers of people with Alzheimer's and related dementias provided $1.4 billion of unpaid care. That's kind of in keeping with the statistic that we showed you in the caregiver slide. And, by 2050, the prediction for the cost of care for dementia could reach over $1 trillion. For $1 trillion. And, this is a disease, the Alzheimer's Association statistic says that every 65 seconds, someone in the US develops Alzheimer's disease. So again, I think of this as a public health crisis and want to advocate or suggest that all of you become, advocates with the Alzheimer's Association to talk to our politicians, to put more money behind this disease, to make it more supported financially like cancer, and to change policy to get Medicare to cover some of the expenses of caring for somebody who needs 24-hour supervision and care. So in terms of treatments, the current FDA-approved treatments include Aricept, which is also called Namenda. Donepezil is the generic. Namenda, the generic for Namenda, is memantine. There's also an Exelon patch for people who can't tolerate the pills, so that's always an option for you to talk to your doctor about. These are not silver bullets. They are effective, and they're moderately or somewhat effective in about 50% of the people who take these medications, and they slow the disease process down by 3 to 6 months. So it's not a significant change in improvement on these drugs. So right now, we're heavily involved, and researchers across the globe are heavily involved in clinical trials that are looking for more effective treatments, cures, and prevention. And if anyone here is interested in learning more about research at the Memory Center, please visit our website, and all of our research coordinator information is listed. I'm also available to answer any questions or put you in touch with research coordinators for any of our studies. So aside from currently approved treatments and clinical trials, we are here to train you about, non-pharmacological ways to modify behavior. So there are medications available to you to help your loved one if they are experiencing extreme behavioral disturbances that cannot be managed non-pharmacologically, but we do want to show you ways to help manage behavior before you explore medication options, which may be necessary at some point, but it's our stance is that if we can change a behavior without a medication, we want to try to do that first. And we do this by providing caregiver training and support. And the fact that you're here is demonstrating that you're here to learn how to do these, how to make these changes. All right, so I talked to you earlier about the cognitive behavioral therapy triangle: thoughts, feelings, and behaviors. I also mentioned that was one framework that this class is made up of, and the next is mindfulness meditation and mindfulness responses. So John Kabat-Zinn is a mindfulness researcher and expert in Boston, and he wrote a book called Full Catastrophe Living. And in that book, he defines mindfulness as the awareness that emerges when you are paying attention on purpose to the present moment without judgment. So, what that means is we're not in the past. Whatever just happened a minute ago no longer exists. And we're not in the future. What happens after this minute does not exist. The only moment in time that exists is this one right now. And so Kabat-Zinn, all of his work focuses on bringing people into the moment. When we're in the moment, we are free of anxiety, which people who are in the future tend to be anxious, thinking about what will happen in the future. And oftentimes people who are living in the past tend to be depressed. So if we're not in the past and we're not in the present, we're okay right now in this moment. Here's another quote. Your mind is like a kindergarten class, and meditating is like trying to get your thoughts to take a nap. So if one wakes up, tell them to gently go back to sleep. If your mind thinks, but I have a to-do list, just ask it to quiet down, take a back seat, and let you be in the here and now. With that brief overview and definition of mindfulness, I want to ask you to practice with me in under a minute what we call the signal breath. The signal breath is a simple stress measurement technique that can help you cope better when stressful caregiving situations arise. It's very powerful because you can use your signal breath anywhere, at any time, during any situation. So if you will, please open your notebook or grab a piece of paper and rate your level of stress or tension on a scale of 1 to 5. 1 being you're totally relaxed, and 5 meaning you're feeling a little bit tense or a little bit stressed right now. So just take a minute, close your eyes, go inside, take a temperature of your system, and jot down your level of tension right now. Once you do that, set your pen and paper down and sit comfortably in your chair. Make sure your feet are planted firmly on the ground. Your back is supported by the back of your chair. You're comfortable yet supported and upright. Place one hand or both on your belly and just feel what your belly feels like as you inhale and exhale. And if you're not feeling your belly rise and fall, try to, on your inhale, exaggerate your belly filling with air, and on your exhale, deflating. So when the air comes in, it's like a balloon, and when the air goes out, when you exhale, the balloon goes down, it deflates a little bit. And now I want you to just take 5 deep breaths. So inhale a deep, full belly breath through your nose. Hold it for a minute and exhale through your mouth. Do that 4 more times. Deep inhale, deep belly breath in, hold, and then full exhale through your mouth. You're alone. You can make noise on the exhale. And after you've taken 3 deep, full belly breaths, again, go inside and take the temperature of your body and rate your stress level to see if it went up or down or stayed the same. And jot down a number of 1 to 5 just to document what it was like to engage in the signal breath. And those 5 deep inhalations through the nose and exhalations through the mouth can help you in any situation. If you don't have time to do 5, do 3. you should automatically feel yourself coming to a place of relaxation or even just slight relaxation or stress reduction when you do the signal breath. So there's your first lesson in mindfulness and your first relaxation exercise for this course. Thank you for practicing with me. So oftentimes, we're not really aware of our mood. We have these moods, they fluctuate, they go up and they go down. But part of what I want us to do in this class is to become more aware of our moods and monitor our moods. I'm going to ask you to monitor your moods every day this week and throughout the class. So as you begin to learn new skills to improve your mood, it's important to monitor and check in, notice, and monitor your mood. So what that means is just like I used this phrase a couple minutes ago, go inside, close your eyes, go inside and ask yourself, how do I feel right now? Or how am I feeling today? In a day, you can be feeling 1,000 different ways. So I want you just to kind of assess how you're feeling. And if you're not sure how you're feeling, can you identify anything in your body that might be telling you how you're feeling? Our body tells us a lot, the body-mind connection. So, go figure out if there's any distress or tension in your body that might help you identify how you feel. And the goal is that if I have you check in regularly with your mood, you will be able to start to notice mood changes that you experience in any given day, week, or month. So as part of this class, I'm going to ask you to keep a daily record of your feelings. The daily record will allow you to identify whether your moods follow a particular pattern. So, for example, some people feel great on Friday after work, and then when Sunday evening comes around, they start to feel a little worse in anticipation of the work week. So we want to note our mood and what we think is causing the mood. And in the next slide, I'm going to show you a daily record to help you record your mood. So it's this simple. We're going to use a 10-point scale, and we're going to give your mood an average rating for the day. 1 is very sad, 5 is okay, 10 is very good, very happy. So on a scale of 1 to 10, I want you to rate your mood right now. And I want you to think about the whole day. So if you're taking this class at 10 o'clock at night, I want you to think about your mood from the time you got up to right now and come up with like an average score for your mood throughout the day. Good things may have happened in your day, and there might have been a lot of stress in your day. So I want you to kind of do your best, imperfect rating on an average mood for your day today. And then after you do that, I want you to think of 2 reasons that might contribute to your mood for the day. So just jot down 2 things that might contribute. If you chose a mood rating of 6, what are 2 things that might be contributing to your mood of 6 rather than 8 or rather than 4? And now everybody's favorite, homework. Homework is what we're calling this, but I like to think of it more as home practice. Ways to practice what you're learning in this class so that they become second nature to you. So on the website where you downloaded this class and your binder information, there's also homework trackers. And in the class 1 homework tracker, you will see a daily mood record and also I'm trying to find, and there should be a daily signal breath rating scale in your binder as well. If there isn't, because we were having a hard time finding ours, just keep it in your journal and jot down your level of tension before and after your signal breath. And for your homework this week, I'd like you to complete a daily mood tracker every day this week. And also do a signal breath every day this week. Either 3, 4, or 5 deep belly breaths in and out, and rate your stress level before and after you do the signal breath. So that's it for this week. I will tell you that the homework will build on itself in the future. But for now, this is it. I want you to track your moods every day and do a signal breath and rate your stress level before and after. If you need any help accessing the homework forms, email me. My email address is right here, felicia.greenfield@pennmedicine.edu. And also, if you have any questions or feedback, feel free to email me that as well. I want to thank you for the completion of the first session, and I will look forward to recording the second session. Thanks very much.